So today in this video presentation, we are going to discuss about the transport and the regulation of the thyroid hormone. Now in the previous recording on the synthesis and the thyroid hormone, we have dealt in length, in detail we have discussed about the synthesis and the secretion of the thyroid hormone. This is just a summary to understand the thyroid hormone transport. Now this is the follicular cell. Iodine is being uptaken by this follicular cell for the synthesis of hormone, and the second raw material that's been taken up is with the thyroglobulin. Over here iodine is been oxidized and these iodine get combined with this thyroglobulin. Now when the thyroglobulin molecules get attached to one iodine ion, it become MIT, 2 it become DIT, and when 3 T3, and when 4 iodine get attached it become T4. Now by the process of endocytosis, again it has been taken up by the thyroid cells and these thyroid hormone is being released. So again T3 is being released, T4 is being released, and the MIT and DIT in which the iodine ion is being attached is again being recycled back for the formation of the 3 and T4. Now approximately 3% of the MIT is there and 33% of the DIT is there, and 35% of T4 and 7% of T3 is being formed. So 3% of MIT and 33% of DIT, from which the iodine is been again recycled for the synthesis of the hormone, which is approximately double the amount which is being taken by the blood for the synthesis of the hormone. Okay, now once this hormone is being secreted into the blood, okay, approximately 4 microgram per day is the amount which is being secreted as T3. 80 microgram per day of T4 is being secreted per day, and a very less amount of reverse T3 is also being secreted into the blood. So maximum amount of T4 is being secreted. Now in the peripheral conversion in the liver and the kidney, again T4 is being converted with the help of D1 and D2 enzyme into T3, and T4 is being again converted into RT3 also, and the rest is being conjugated and being metabolized and be liberated out of the body. Now if the recycling of the iodine from the MIT and DIT, as we have talked, it is double the amount which is coming from the blood. Now it is happening under the presence of an enzyme. The name of the enzyme is iotyrosine dehydrogenase. This is the name of the enzyme. Okay. Now suppose if this enzyme is absent, or if there is a deficiency of this enzyme, for example in congenital hypothyroidism it happened, then practically what will happen, the less amount of iodine will be available for oxidation, and as a result of that less amount of T3 and T4 will be formed. Now we will see the difference between T3 and T4. 80 microgram of the T4 is being produced per day, but only 5 microgram of the T3 is being produced per day. So we can see that the amount of T3 which is being produced is much more less as compared to the T4. Even though T3 production or the synthesis and secretion of T3 is less, but it has got more biological activity as compared to T4. As compared to T4, it has got approximately 10 times more activity, biological activity comparable to T4. Now an additional 25 gram per day of the T3 is also being produced by the peripheral monodeiodination of the T4 in the liver and the kidney. So whatever amount of thyroid hormone is being produced, okay, T3 and T4, okay, now an additional 25 microgram of the T3 is also being formed form in the peripheral conversion in the kidney and the liver. So 25% of the T4, 25% of the T4 is being converted into T3, and when one iodine is being removed, okay, it is converted into T3, and also some decreased amount of reverse 3 is also being formed. Now on the other hand, the patient who are suffering from, these are the list of the critical illness patient for cancer, starvation and so on. If in cases of this type of patient, okay, there is a decreased amount of T3 being produced from the T4, but there is an increased amount of reverse T3 is being formed. Now these are the list of condition, okay, critically ill patient and cancer, starvation. We don't want, what is desirable, we don't want in these patients their metabolism to be increased. We want their metabolic rate to be decreased. Okay, now this can only be accomplished when there is a decreased amount of T3 is there. Okay, so this is the physiological basis of the altered amount of the thyroid hormone in this non-thyroidal illness syndrome or thyroid sick syndrome patient is there. Now, although reverse T3 is being produced in large amount, okay, this cannot be taken as a basis to differentiate this type of patient from the hypothyroidism patient in the critical ill patient. Now, when T4 is converted into T3 in the peripheral tissue, there are various type of enzyme that is going to help for the conversion. There are basically three type of enzymes which are present in the body: D1, D2 and D3. So D1 is present in the liver and the kidney. D2 is being present in the pituitary muscle in the central nervous system. D3 is being present in the brain and skin, and also present in the human placenta for the protection of the fetus. Now in patient who are state of inflammation or critically ill patient, we don't want the T3 4 to be increase, we want BMR to be decreased. So how does that T3 is being reduced? By the virtue of the increased amount of D3. What does it do? It decreases the peripheral conversion of T4 into T3. Now, thyroid stimulating hormone is secreted from the thyroid cells of the anterior pituitary. It has been seen that it has gone dual pattern for the release. One is the pulsatile and the second is the circadian rhythm. So this thyroid stimulating hormone begin to increase in the morning. It has got low level. So late afternoon or in the early evening, it begin to rise. Okay, and the maximum amount of this secretion the hormone will find just before the sleep at about midnight. Then after midnight again it began to decreases, okay, until it become a very low in the morning. So this is the pulsatile secretion, it is releasing in pulses, okay, and this is in the circadian rhythm of 24 hours. Now pulsatile is being released, okay, to maintain the homeostasis, okay, and you can see a clear cut of the circadian pattern. It is it is low before the noon, okay, and it has got maximum in the midnight, showing the circadian pattern. Now we are going to see how T3 and T4 is being transported in the blood. Now we will see, once T3 and T4 is been secreted in the blood, how does the transportation take place. Okay, now these thyroid hormone are not soluble in water. Okay, if these hormone would have been soluble in water, then there wouldn't have been any special protein to carry this hormone to their target cells. So there are basically three types of binding globulin proteins are there. which is being synthesized by the liver. Okay, so all three different types of protein which will be associated with the T3 and T4 is being made in the liver. The name of the first protein with which the T3 and T4 combine is the thyroid hormone binding globulin. Commonly it is known as TPG. Okay, now 70% of the hormone is being associated with this globulin. Second is the pre-albumin. Okay, 50% of the T3 and T4 is being associated with this hormone, and rest 15% is of the hormone is being associated with the albumin. Okay, now when these T3 and T4 get associated with these binding proteins, okay, only very small amount of approximately 1% of the hormone is free in the circulation, and this is the free circulatory hormone which will be producing their physiological or biological effect. Okay, so T3 and T4 is released slowly to the tissue. So once T3 T4, when it comes out of the follicle, okay, it combined with these proteins, three types of different proteins. Now again within the cytoplasm of the cell, they again combine with the different sites within the cytoplasm, and slowly from there they release it to the nucleus of the cell to produce various type of proteins. So at two places it combined, one in the blood and second in the cytoplasm of the cell. So 99% of the T3 and T4 combine immediately with several of the plasma protein that we have just studied just now. And okay, so 99.98% of the T4 in plasma is bound, and only the free T4 level is only about 2 nanogram per deciliter. That's equivalent to only 0.03% of whatever of T4 is being produced. Okay, now this 0.03%, okay, is the free amount. Okay, or 2 nanogram per deciliter is the free amount. This will produce the physiological effect, or the bound form of the hormone will never going to produce any physiological effect. In that way, T3, it is 99.8 combined with the proteins, okay, listed above, and only the free T3 available is 0.3 nanogram. Okay, so only this 0.3 nanogram will be responsible to produce the physiological effect. Now in this slide, just concentrate on this T4 and T3. Okay, now you can see various proteins. Albumin is there, TTR is there. These are the binding proteins with which T4 and T3 is being associated with. Okay, just see the amount percent of free T3 and T4. Okay, so T4 is 0.03 and T3 is 0.3 only of the percent of the total amount which is secreted, and this is the free hormone which is going to produce the physiological effect. Bound protein, bound form of T3 and T4 will never produce the physiological effect. Now we are going to see why these thyroid binding proteins are so important for this T3 and T4. Okay, now T3 and T4, which is being found in the thyroid gland, it combined with the thyroglobulin molecules in the thyroid gland, and it remains there. Okay, whenever there is a requirement of thyroid gland is there, it is going to be released. So preformed of T3 and T4 is being stored along with the thyroglobulin molecules within the follicles. Okay, so one reservoir is there in the thyroid gland itself there. Now if no iodine is available, okay, then thyroid hormone is going to be secreted and homeostasis is going to be maintained. So what is happening? A large buffer pool is there in the peripheral. If large amount of T3 4 is there, from T4 T3 is being made, okay, by the removal of one iodine ion. So T4 is acting like a large buffer. When required, large amount of T3 can be found from the T4. Secondly, it prolongs the half-life. Okay, 1 is for the T3 and 8 days is for the T4. Okay, and secondly, as I've talked to you, it is a reservoir for T3. Now this thyroid binding globin has a molecular mass of 54 kilodalton, of which 20% is made up of carbohydrate. The gene for this TPG molecule is located in the X chromosomes XQ22. Now it has got half-life of 5 or 8 days. Different books has given different days. The affinity for T3 is approximately 20-fold less, 20 times it is less for T3 as compared to the T4. So it is going to very tightly associated with T4 as compared to the T3. The binding of the T4 and the T3 by this molecule is going to be inhibited by some of the drugs listed over here. So clinically, when you are giving these types of drug to the patient, okay, you will have to evaluate that whether to give this drug or not. Now this is another protein, okay. Now it exists in the part as a complex with the retinol, okay, hence the name is there. It has got 4 identical polypeptide chain. The molecular weight is again 55 kilodalton, okay, which is present in the plasma, and the amount of which it is present in the plasma is 4 millimole per liter. The half-life is 2 days, and it is present in the choroid plexus, and in the major portion of this TTR is being produced in. Now, when we are talking about albumin, it has got low affinity to combine with the T3 and T4 compared with the TBG or TTR. It of all the lot of total amount of thyroid binding globulin and other protein that associated with the T3 and T4, it accounts for only 10%. Now, if there is a change in the albumin level in the plasma, okay, it is going to produce a very little effect on the total hormone concentration. It is produced by the liver. So, is there any other protein that can bind with the T3 and T4? Yes, there is one more protein available, which is known as the T4 binding lipoproteins. So, this lipoprotein can bind with T4, which is only 3 to 6%, very small amount. But its association with this lipoprotein physiological significance or the physiological function is still unknown. Now the regulation of the T3 and T4 hormone, which is being produced by the thyroid gland, is regulated by two main mechanisms. One is the auto-regulated mechanism, which reflected the total amount of the availability of the iodine ion, and secondly, it is being regulated by the hypothalamus and anterior pituitary. So we are going to see what is auto-regulation of the thyroid hormone. So the rate of iodine uptake incorporated into the thyroglobulin is influenced by the amount of iodine available. Okay, so if the iodine level is low, okay, then there will be an increased iodine transport into the follicular cell, or if there is a high level of iodine is available, that is going to decrease the iodine transport into the follicle cell. Now you can remember that the transport of the iodine is basically taken through the NIS, sodium ion synthetase. Okay, so there is a negative feedback regulation of the iodine transport by the iodine. Now from the thyroid gland, 80% of the T3 is being formed and only 20% of the T3 is being formed. Okay, and when required, T4 is being converted into T3 by D1 and D2 enzyme in the liver and the kidney, which is the peripheral conversion of T4. Okay, Suppose if there is a decreased amount of T3 and T4 is there, okay, so it is going to stimulate the hypothalamus to increase the thyrotropin releasing hormone, and this is further going to act on the anterior pituitary thyroid cells and will increase the amount of thyroid stimulating hormone, and this thyroid stimulating hormone is going to further stimulate the thyroid gland for the production of T3 and T4, and just the opposite is going to happen. Okay, if the amount of T4 and T3 increases, okay, it is going to inhibit hypothalamus and the anterior pituitary to decrease the amount of T3 and T4. Okay, so optimum level of iodine is required for the synthesis of T3 and T4. If it become very high, okay, if the iodine content in the diet is very high, or exogenous iodine you are taking in a very high amount, okay, then what is going to happen in the synthesis? The organification is going to be inhibited. Organification means iodine is being converted into oxidized form, and this oxidized form of iodine get combined with the thyroglobulin molecules. Okay, so the organification is being inhibited, okay, and thereby decreases the T3 and T4 synthesis. So high amount of iodine will decrease the T3 and T4, and this effect is known as the Walsh-Chaikov effect. Okay, the amount of T4 is 8 microgram per deciliter and T3 is 0.15. Now it is the amount of free T3 and T4 level. It is going to give feedback to the pituitary gland as well as to thyroid gland for the production of T3 and T4. So the free level of hormone T3 and T4 is going to regulate, and not the bound form of T3 and T4. Okay, now this T4 level or T3 level is with equilibrium with the plasma bound and as well as with the tissue bound. So these two are the large pool for the T4, and when required T4 is converted into T3. Now suppose if the plasma protein increases, for example during pregnancy, when estrogen stimulates the liver, and as a result of that large amount of protein is being increased. Okay, now comparatively when the plasma protein increases, okay, then what's happened, the free T4 level falls, it decreases. Now as a result of that, it stimulates the pituitary gland to release thyroid stimulating hormone, which therefore stimulate the thyroid gland for the production of T3 and T4. When the thyroid hormone is being produced, it again maintain a equilibrium with the plasma protein bound T4. The equilibrium is being formed by the newly synthesized thyroid hormone and the plasma protein bound form. But one thing is to be understood, and along with it again free level is being come back to its normal level. But thing is to be understand here that the concentration of the free hormone and the rate of their metabolism and the rate of TSH secretion are absolutely normal. Okay. Now thus the opposite is going to happen if the plasma protein decreases. If it decreases, the free T4 is going to increase, and further it is going to inhibit for the production of thyroid hormone, and once again what will happen, a new equilibrium is going to maintain. Now in this slide you will be able to see the different three type of protein which combine with the T3 and T4. As well as the plasma concentration of these three protein is concerned, TBG is in minimum amount and albumin is in maximum amount. Okay. Now when we are comparing the amount of circulatory hormone which is being bound with this protein, okay, you can see that only 46% get combined with the TBG. Okay, and as far as the T4 is concerned, the maximum amount 67% get combined with the TBG, and minimum amount of 30% get combined with the albumin. But when we are talking of T3, okay, T3 maximum combined with the albumin. Okay, and minimum it's combined with the thyroid pre-albumin. Thank you so much.